Everyone. I'm Kathleen Kearns, the Vice President of External Affairs for the New York Genome Center. And it's always my pleasure to welcome our guests for these evening talks, which are very generously underwritten by a member of our Board of Trustees named Wesley Janeway and her fund at the New York Community Trust called Pyewacket Fund. So I extend my thanks to her for underwriting these events for us. It's a pleasure for me to greet you for such an important topic tonight. And we're particularly delighted to have our friend Fran Visco here from the National Breast Cancer Coalition, with whom we're so honored to be a partner. And you'll get to hear from my wonderful colleagues, Dr. Yaniv Ehrlich and Dr. Dan Landau, on this topic which affects all of us. It affects everyone I know, some way or another, and I'm sure all of you. After the talk, we'll have some questions, and then I invite you all to please join us and stay for a drink or bite to eat in the cafe next door. Thanks very much for coming. We appreciate it, and I'll look forward to meeting some of you after the talk. Thank you. Yaniv?
Welcome, everyone, to the New York Genome Center. So usually we do these science talks, evenings, open to the general public. And today we have we put a diverse group of individuals, and we have a leader in patient advocacy, Fran Visco over here. We have Dan Landau, that he's an MD PhD that studies the cutting edge of breast cancer using a high throughput sequencing. And my name is Yaniv Ehrlich, and I'm a geneticist. So this is a diverse group of people, but I think what is common for all of us is that we are not accepting the status quo in breast cancer. We want to change the status quo. We want basically to see how we can win the war against breast cancer. So our first speaker is Fran Visco. Fran is a more than 25-year breast cancer survivor. She is the president of the National Breast Cancer Coalition and a member of its boards of directors and executive committee. In 1993, President Clinton appointed Ms. Visco as one of the 3 members of the President's Cancer Panel, and she was the first consumer to chair the integration panel of the Department of Defense peer-reviewed breast cancer research program. Fran, please, let's welcome her.
So I have an opportunity to talk to you a little bit about the National Breast Cancer Coalition, our Deadline 2020, our Artemis Project, and the work that we're doing with New York Genome and with Yaniv. So the National Breast Cancer Coalition was formed in 1991 as a coalition of organizations across the country. And we have 2 arms. We have an advocacy arm, and we have a program arm. And we were brought together as a coalition because we wanted to change the systems of breast cancer. There are many groups, many of our member groups, that do direct services that help individuals, one-on-one support. But there wasn't anyone who was actually working on the systems, the public policy, the system of science and research. And so that's why NBCC was formed with our mission to end breast cancer. Now, the advocacy arm of our organization, every year we set a legislative and public policy agenda. And that agenda is determined by our board of directors, which is a board of grassroots organizations from across the country. And the accomplishments of that advocacy arm include, we brought about more than $3.5 billion new dollars for breast cancer research from the defense budget alone, launching the Department of Defense peer-reviewed breast cancer research program. We brought about the CDC Breast and Cervical Cancer Treatment Act because as people interested in system change, we recognize that just screening and finding cancer is not enough if there isn't access to care to treat that cancer. And so we wrote a piece of legislation and we educated Congress and the White House about it, and we got that bill enacted into law, resulting in a system of access to care for thousands of uninsured women across the country. We have worked on a number of public policy issues in breast cancer, including bringing about the National Action Plan on Breast Cancer, working with the Food and Drug Administration, developing the Accelerating the End of Breast Cancer Act, getting our voice heard on the Affordable Care Act and Access to Care, and many others. Now, the program arm of NBCC is integrated with the advocacy arm. If we're going to bring about more money for research, we want to make certain those dollars are well spent. And how do we as the lay public understand how they should be spent? And so one of our programs is developing training and education programs for the lay public in science, and training in advocacy also. We have continuing education for the individuals who take our science programs. We have an online center for training. We train team leaders who lead teams of advocates on Capitol Hill to advance our public policy agenda. And we train leaders at summits in order to make certain that the world of breast cancer is focused on the mission to end breast cancer. And we also have a science and research component to our programs. We work on clinical trials that we believe will really advance and change the paradigm of treatment. And one of the trials we worked on in the very beginning was the pivotal trial for Herceptin, the first targeted therapy for breast cancer. And we will talk a bit now about our Artemis Project. But first, I want to talk about Deadline 2020. We, in the about 2010, we looked at all of the accomplishments that we had brought about in breast cancer. And we also looked at the reality of breast cancer and the fact that there isn't very much progress in breast cancer. Even though the public perception is difficult, the statistics tell a very different story. And so we thought about what we can do to bring back urgency to breast cancer, and as Yaniv said, to really shake up the system and challenge the status quo. And so we launched our campaign, Breast Cancer Deadline 2020, to know how to end breast cancer by 2020. Well, how are we going to get there? We developed a strategic plan of action and a blueprint with a number of different components to the blueprint on how we will achieve that deadline in 2020. And it really is designed around three goals: the research that's needed to end breast cancer, global access to necessary information and care, and the influence of leaders everywhere and the strategies to end breast cancer. Now, again, in order to achieve our accomplishments, in order to make certain that the deadline work is on track, and to make certain that the billions of dollars devoted to breast cancer research are spent answering questions that will save lives, we developed our training programs. And I want to talk to you just briefly about Project LEAD. Project LEAD is about getting trained advocates a seat at every table and leadership roles where decisions are made about breast cancer. Project LEAD graduates peer review proposals in the scientific system. They help set a research agenda. We actually collaborate with researchers to design research. We have training in understanding the process and the language of science. And for Project LEAD, there is no fee, but there is an application process. And you're going to hear a number of concepts later from Yaniv and from Dan. And if you have trouble understanding them, if you're a lay member of the audience, please consider applying for and taking Project LEAD. So what do we teach there? Our curriculum includes the biology of cancer, principles of genetics, an introduction to epidemiology, immunology. So we have trained and educated advocates who sit side by side with scientists and work on our deadline blueprint. But we realized even that wasn't enough, because we wanted to make certain, again, that research was focusing on issues of importance to us. And so we launched the research arm of our deadline campaign, which is the Artemis Project, of which Yaniv is a member. And that focuses on two arms. One is primary prevention, stopping women and men from getting breast cancer in the first place. And the second is preventing metastasis, because breast cancer does not kill you. It's the spread of breast cancer, the metastasis of breast cancer, that kills women and men. And we wanted to look at metastatic disease from a new perspective, in a new way, in addition to the clinical trials and other work that we were doing. So the Artemis Project is led by advocates, and it is a collaboration of scientists, international collaboration of scientists and advocates to look at those two main questions. The process is we had catalytic workshops to generate scientific questions, and those questions then drive the research direction and the allocation of the limited resources that we have in Artemis. Teams of advocates and scientists work together on designing research plans and setting goals in the Artemis Project, and we've managed to raise a little bit of money to give seed grants, one of which was given to the DNA Land Breast Cancer Project that we're here to discuss in more detail later. We have webinars when issues come up among the scientists and advocates in the Artemis Project that need to be immediately addressed, and we have regularly scheduled conference calls to move forward on certain projects. Now, all of these research questions are developed by that diverse collaboration, and they are really designed by and implemented by a diverse collaboration of scientists and advocates. It's not just one institution or one individually. It really is a true collaboration. So our Artemis topic project on prevention of metastasis, how do we stop people from dying of breast cancer? We have worked on this issue since 2013 when we first raised the money for that aspect of Artemis. And we've had a number of meetings that are looking at questions and focusing in part on dormancy. Why do tumor cells lie dormant? Why are you diagnosed? Someone mentioned to me tonight that Olivia Newton-John was diagnosed with metastatic disease, and that was announced yesterday. Her initial diagnosis was many, many years ago. What's been happening with the tumor cells in her body that suddenly she now is diagnosed with metastatic disease? What is that process? Can we intervene in it? Can we understand it and stop it? So we want to better understand the process of metastasis in our Preventing Metastasis project and understand how to intervene in that process so that we can not just cure existing metastasis and figure it out, but we can also stop people from getting metastatic disease so that people will not die of breast cancer. I mentioned also that we have a primary prevention project, and that we are specifically looking at the moment, at a preventive vaccine in breast cancer. And we have a team, a collaboration from Artemis working on that. We've identified the targets. We've begun to prepare the necessary package to present to the FDA. So we're moving forward in that arena also. Now, in the Preventing Metastasis project, as I said, we have the opportunity to work with incredible scientists from all over and incredible advocates. And Yaniv was one of the scientists who worked on the Artemis Project. And he brought to us this idea, the DNA Land idea, and we were very excited about the partnership with him and with Joe Pickrell in order to develop this, because this is, as you'll hear more, really a way of crowdsourcing data. We will be crowdsourcing data, as he will explain, and individuals will donate their data to DNA Land, to the Breast Cancer Project, and hopefully we will develop a database of genomic information that can be used by researchers everywhere to answer questions like the one I just raised. What is the profile of an individual who develops breast cancer that then metastasizes, that progresses? Is there something about this genomic data that can lead us in the right direction? And it may even be able to answer questions about risk. Who is at higher risk of breast cancer, not just who is at higher risk of dying of breast cancer. So we're very thrilled to have this collaboration. Project lead trained advocates worked on it, worked on the clinical questionnaire. And again, I think the important part to remember is that our deadline project is led by advocates. Our blueprint and strategic plan is real. It is not a PR campaign. We are really working on moving this forward. We are working on two issues that do not get enough attention: primary prevention, preventing metastasis. And we're able to do that in part because of the very sophisticated and unprecedented science training programs for lay advocates that we conduct. And we are at the point now we were able to partner with people like Yaniv in order to move forward on DNA land. Thank you.
So I'm going to speak about DNA Land. This is a joint project with the National Breast Cancer Coalition. And before I start, I want to start with a poll. How many of you heard about consumer genetics? Companies like 23andMe, Ancestry.com, MyHeritage. Raise your hand. Okay, most of you. Terrific. How many of you have been tested with one of these companies? Very good. I'm here to recruit you to DNA Land. This is my agenda. We are counting on you. So let me kind of like tell you a bit what is DNA Land, what is the story, what is the value proposition, and why we need you to be part of this project. So I think most of you heard about the Angelina Jolie story, and where she was tested. She knew that she has some breast cancer history in her family, and she was tested for a single gene called BRCA. And the genetic test identified a mutation in this gene, which means that she has about 80% chance to develop breast cancer in her lifetime. Now, without any signs of breast cancer, without any symptoms of breast cancer, she took a very aggressive step of double mastectomy. And by doing that, she reduces her risk to about 5%. Now, we kind of like maybe so used to genetic information that it sounds, that's a logical story, but think about it. We have a test to predict that someone is going to develop breast cancer, and we can lower, without any symptoms, without having any cancerous cell in the body of this person, we can tell this person, go to this very aggressive treatment, by the way, and you can lower your risk. So I think this is kind of like the power of genetics. We can have one test and we can predict something and have some insightful, information that we can act upon. But in this project, we are not interested in screening healthy people, kind of like to understand what biases people to develop breast cancer. We try to understand something very different in this project. We try to understand why certain breast cancer patients later on relapse. After they got some treatment, they relapse and they develop a much more aggressive tumor that eventually might kill them. So this is what we try to understand in this project, to understand the genetic differences between individuals and what causes certain individuals with breast cancer to basically recover and have healthy life, and other people actually to being predisposed to develop a relapse. Okay, so what's the value? Why are we interested in that project? Because if we understand the genetic differences between people that develop relapse and between people that don't develop relapse, we might be able to later on suggest some drug targets. Maybe we can also stratify high and low risk patients. We can say, oh, this person is much more susceptible to develop a relapse, so we should have a much more aggressive treatment or have much more frequent screening of this person. And this person maybe have a lower chance, so maybe we should not go with such aggressive treatment and have more sparse screening. Another thing is that we might be able to understand causality. One of the shortcomings of epidemiology is that we just see associations. We have two variables and we see some link, but we don't know if there is a causality between these variables. Let me give you an example. For instance, we know that BMI is associated with the chance of a relapse. Now, one option is that really BMI, the level of fat in the body of the patient, is causing to develop a secondary recurrence of the tumor. That's one hypothesis. A second hypothesis is that people with higher BMI maybe have worse access to healthcare, because we know that BMI is inverse correlated with income. And this is the reason why they have relapse, right? So what should we do? Should we put now breast cancer survivors on some diet to reduce their BMI? Because if this is just some mere association, we didn't do anything by that, right? Just by putting them on the diet. Genetics can give us some smart epidemiological tools in genetics that will allow us to basically disentangle these observations and suggest causality. Okay, so kind of like the problem is that if you do the genetics of relapse in breast cancer right now, we don't know anything. Here is a study of genome-wide association study of breast cancer relapse. And look how sad is this title over here, null results. Null results, if you're not a scientist, means that we have nothing exciting to report. We didn't find anything. Okay? So actually, why do I give this talk? If people didn't find anything, what's the value proposition here? Why we are interested in the genetics of relapse? So kind of like, let's go to this abstract, and you see that they only had 1,000 participants, only 1,000 genomes to look at the differences between people that develop relapse and people that didn't develop relapse. Now, if we go to other diseases, other traits, and we look at the genetics of these traits, for instance, schizophrenia, you see also that they didn't find, when they scanned 1,000 cases and 1,000 controls, they also reported null results. And this is around 2012, I believe. But once they had a bigger study, where they had about 40,000 cases, suddenly scientists were able to understand the genetic basis of schizophrenia. So this is the hypothesis that we work in this study of relapse. When you have a small sample size, you don't see anything. But once you get to a very large sample size, you start to understand the genetic basis of the disease. And this is why we need you and why we need a lot of people in this study. Okay, so how are we going to do this, right? These studies are quite expensive, and we don't have infinite money, although we wanted to have infinite money, but we have some constraints over here. So together with a friend, we thought about a method that can be very cost-effective to get to these numbers. And the method that we're using, kind of like the observation that we have, is that we live in the era of consumer genetics. You heard about these companies, 23andMe, Ancestry, MyHeritage, FamilyTreeDNA. All these companies sells to people DNA tests. And they are very similar to the tests that we use in the lab to do these genome-wide association studies. And they doesn't cost so much, these tests. So today, basically, there are about 6 million people in the US that were tested with one of these companies. So what we thought is maybe we can build a website so people can come. If you were tested with one of these companies, you can kind of like, when you throw a party and you bring your own beer, kind of like party. We do a party and we call it Bring Your Own Genome. You come to our website with, if you've been tested, and bring your own genome and donate your genome to scientific studies. So you know what they say, if you build it, they will come. So we built a website, and they came. And this is actually, this slide I made it like a week ago. We had 48,000 individuals. Now we have about 49,000 individuals already in this website. Okay? Every month we have about approximately 2,000 new individuals are donating their genome to our website. And the website is called dna.land. So why do people come? And the reason that people come is, first, we consent. This is not a website. This is not like Facebook or some website that you just give your data and we don't have any ownership. We consent you to participate in a scientific study. Our consent is written in plain English. This is not for Harvard JDs, and I know there are some lawyers in the room. Okay? So people that you don't need to be a lawyer to understand what we are asking you to do. 1,500 words, very simple. It's balanced. We talked about kind of like privacy concerns that you might have when you give your genome. And we also have a skin in the game approach. So when I ask you to give me your genome, I already give you my genome. So my genome is publicly available, and also Joe Pickrell, my partner in crime over here. We give our genome for when we ask you to donate your genome to this secure website, we put already our genome out in the plains because we don't want to ask you to take any risks that we are not taking ourselves. And my genome has been out there for, I think now, 2 years, nearly 2 years. And so far, I'm okay with it, okay? And we actually we were pleased by the response of the community to our website. Misha Angrist is a professor of bioethics at Duke University. And he tweeted, Twitter today, this is the most valuable media, right? He tweeted, "I really like that DNA land consent doesn't make me feel like I need to take a shower." Okay, so this is from bioethicists, and that's pretty nice. Okay, another thing that we do, we ask you to participate in DNA land, and we hope that you are motivated enough because you want to eradicate breast cancer, but we also know that we need to give you something back for fun, right? So we do some fun things when you come to DNA land. For example, we will go and we try to search for relatives in the website. So every day, we will scan all the genomes in the website, and we try to show you people that you may be related to. And this is a cousin that I'm related, I just don't give the name of this person. And we allow you to find relatives. Now, why this is fun? So, and let me just skip one slide. So we have here Erica, and she's the executive assistant of the faculty at the New York Genome Center. And Erica gave her results to DNA Land. Now, Erica was tested with 23andMe. Now, Erica is a long friend called Ronnie Lazarus, and you see them together here, and this is from their childhood. Erica here is hitting Ronnie or something like that. I don't know what's going on. It's a bit rough. Where is Erica? Yeah. So watch out from Erica. She can be violent. And so now she and Ronnie knows that they are friends for like dozens of years. But Erica was tested with 23andMe. Ronnie was tested with Ancestry DNA. These are two different silos. But when they came to DNA Land and put their genomes together, suddenly they realized that they're related to each other. They have some shared DNA markers, so they are some distant cousins of each other. So this now friendship became some family, mishpuche, right? So family matter. So this is one of the fun things that you do when you come to DNA Land. Another thing that we do is that we will analyze your genetic heritage. So this is my own genome. I'm a half Ashkenazi Jewish over here. My other half is from the Jewish community in Tajikistan, and this is the other components. You come to DNA Land, you get this thing for free. We don't charge you anything. We want you to participate in our study. Okay, so for this NBCC project, we set up a very simple questionnaire. You come to DNA Land, you donate your genome, then we will ask you to take this questionnaire. You document your family history about breast cancer, and we also consent you that you're going to give the data to the NBCC. And this is an important point. We don't want to create a new silo that I just going to have all the data about breast cancer and it will stay with me. No. All the data that you come to DNA Land and participate in this questionnaire for breast cancer will go to the NBCC. It will go back to a patient advocacy group, and they will manage this data set. So they can give it to other researchers. So we're not creating another silo. We're going to enable the community to study breast cancer. And so far, we launched this project about 1.5 months ago, this questionnaire. And we have about 3,000 people that answered our questionnaire so far. And out of these 3,000 people, we have about 500 individuals that had breast cancer history. And they're informative, and we can use now their genome and see what is the outcome for relapse in their case. And something innovative that, and by the way, if you were not tested with one of these companies, you can go to these companies and purchase a test. A disclaimer, I'm a consultant of this company, but you can also use the competitors, but just put a disclaimer. Okay, so another innovative part of this project is that if you are a male, you can help. We are not looking only for females. Now you can say, I'm a male, I don't have any breast cancer, how can I help? We published a paper in Nature Genetics this January, and we showed that we can use first-degree relatives to study the genetic architecture of traits. We can go to males, ask them, do you have breast cancer history in your family? Maybe your sister, maybe your mother, maybe your daughter. If you do, since you share half of the genome with this person, we kind of like already see something about breast cancer from your genome. And this is the reason, so if you're males, if you have males friends that have breast cancer history, tell them about this website. They can also participate. So this is kind of like the summary for this part of my talk. So DNA Land, this is kind of like a website that we want to empower patients. And we ask you not to donate money, but to donate data to this website. And also by donating data, you get fun, I want to say it, to emphasize that, you get some fun experience about your genome. We do many fun things. It's not just about giving the data and walking away. We're going to send you some nice reports so you can see them and learn something new, hopefully, about yourself. Consider sharing your data to DNA Land. Ask family members, ask friends, ask your mailman, I don't know, ask people to help us to spread the word. We count on you. We don't have like, a Facebook campaign that we're going to put for advertisement. We are relying that on the word of mouth of people like you that are interested to change the status quo in breast cancer. Remember, sharing is caring. Thank you very much. All right, so now I'm going to introduce the next speaker, Dan Landau. And Dan is going to tell us about liquid biopsy, and that's a really mind-blowing technique that is going to change cancer screening. So Dan Landau received his MD from Tel Aviv University and his PhD from Paris Diderot University. Did I pronounce it correctly? I tried. Dan Landau was trained as a hematologist and oncologist at Yale University and completed postdoctoral fellowship at the Broad Institute of Harvard and MIT. He has received numerous awards, including the Boris Wellcome Fund, Stand Up to Cancer, and the National Institute of Health Big Data to Knowledge Initiative. His research focuses on developing novel quantitative biology approaches for the study of somatic evolution. His ultimate goal is to understand the basic dimensions that determine cancer's evolution and to devise therapies that directly anticipate and address it. Please welcome Dan.
Hello, everyone. So I'm skipping the slides today because I really value the Q&A and the discussion part. So I'll try and kind of tell you a little bit about the work that we do, a couple of major themes that we deal with, and then we can move to the Q&A where we can all kind of have an open discussion. So just a little bit about me. I'm an oncologist and a hematologist. I practice at New York Presbyterian, but also I have a lab that is dedicated to cancer genomics. And we work both here at the New York Genome Center and at Weill Cornell and span the breadth of very basic science in the lab, in dishes, in vitro, and so on, to the application of this knowledge and these insights to patient care. So the first concept that I would like to kind of touch upon, and it's related to what Yaniv was saying about liquid biopsy, and it's related also to the points that were made by Fran about targeted therapy, is that to some degree there has been a lot of progress when we think about clinical care in breast cancer. And as Fran mentioned, HER2 therapy, it was one of the first instances where scientists have learned to target particular molecules that are very specific to the tumor and use this therapeutically to help patients. And as we are sequencing more and more tumors, we're coming across multiple new targets like this, things that are unique to the tumor and that can lead to new targeted therapies. And in some subtypes of breast cancer, as clinicians, we're faced with some degree of fortunate challenge that now we have multiple therapeutic options to offer patients. But that also brings an obstacle or difficulty in terms of optimizing the care to a particular patient. And that introduces the concept of precision medicine. The idea is that if we perform sequencing of the patient's sample, we can try and find what are exactly those type of targets and match them to the right drug. If we can match them to the right drug, maybe the responses would be better, and maybe the toxicity, the side effects would be less pronounced. But our work in other malignancies and the work of many other people actually showed that paradigm is a little bit naive. And the reason it's naive because it assumes that all the cancer cells in one individual are identical. That's sort of the perspective we had to begin with when we were thinking about cancer. It's a disease in which one cell sort of multiplies itself indefinitely, and creating exact copies. But in fact, as the cancer grows and create those copies, it actually starts diversifying. Just like if you put bacteria in a dish, they would start acquiring different mutations, different genes, as Yaniv was explaining. And that diversity actually leads to a therapeutic challenge. And that's because as clinicians, we are faced with the challenge of treating not one disease entity, but rather thousands of diseases in each individual patient. They have different populations, clones, that are unique one from another genetically, and that allows that cancer to find recipes to overcome our therapies. So now we want to come to a place where we're able to refine this strategy of precision medicine, where we just statically profile at one time point the cancer and tailor the therapy to that cancer. We want to, just like we do with other processes in life, we want to have iterative closed loop systems. So we want to be able to measure the genetic of a tumor, understanding that there are multiple different populations, multiple clones, multiple different cells, and then see how they respond to therapy and adapt their therapy. So think about how a patient today is treated for diabetes, right? They have glucose sensors that measure the glucose continuously and then adapts the insulin treatment such that we optimize exactly the level of sugar they should have. In contrast, what we do in cancer today is we measure things at one time point and then start a therapy, and sometimes the only next time point that we can see if things worked or not are months or even years after that time point. So we would like to reach a place where we're able to continuously monitor how different populations within the cancer are responding to different drugs and use it to iteratively optimize therapy. The challenge comes from the fact that in order to do this, we actually have to get a piece of the tumor. And because the tumor lies inside the patient's body, that means that we have to submit the patient to an invasive procedure like a biopsy. That's obviously very difficult to do, and it's very difficult to do iteratively multiple times to be able to assess response. And now comes this very innovative technology that helps us refine therapies and to do this iterative closed loop engineering of therapy where we can give therapy, see how it responds, and adapt our approaches. And it turns out that the breast cancer, whether it's in the breast or in a metastatic site, because metastasis is indeed a very significant challenge, it sheds parts of its DNA into the bloodstream. So part of the cells lose their DNA and it gets mixed up in the bloodstream. And it turns out that we can take a blood sample from the bloodstream and try and find those rare pieces of DNA that's coming from the tumor and use that as a handle to do exactly this ability to iterate and to measure things continuously to optimize therapy. So that is a major area of focus for the lab. What we're trying to do is to develop new methods that would allow us to go after those DNA parts that are spilled over from the tumor so we can start understanding what is happening dynamically, right? Everything that we do in life, we do dynamically. We have thermostats to control the air conditioning. We have glucose measurements and insulin. We know that from the engineering perspective, if we have an ability to impact the process dynamically, we'll be much better off. And for this, we need this liquid biopsy technology. So that's for the side of those subtypes of breast cancer where we actually have multiple therapies, maybe not ideal, but already achieving some good responses in patients. And one of the challenges we face is how to optimize combining them. But there are other subsets of cancer where unfortunately we have little to offer. And there, as I think was also mentioned by Fran and Yaniv, one of the major tools that we can use are tools that are related to early detection. So the idea is that if we can detect cancer early, then we can perhaps intervene before it had an opportunity to spread, before it had an opportunity to grow in size, to diversify, and so forth. And we thought that it would be useful to use this approach of liquid biopsy. If we can find traces of the cancer genome in a blood sample, then potentially you could be able to go to a doctor, just like you check for cholesterol, you would be able to check for cancer. And that is indeed a very exciting prospect that has a lot of scientists working on it, including us. But there is a challenge. And the challenge is that those DNA fragments are very rare. So think about it. If we think of someone's body and all of the cells are contributing to these small DNA pieces that are found in the bloodstream, only a very small minority of those would come from the actual cancer. So we come to a problem that's a little bit like the lottery. We try to sequence a lot of molecules in the hope that we would find that one molecule that will tell us there's cancer. And it turns out that our current methods are pretty much as effective as imaging, or mammography in the case of breast cancer. So we're able to do with this liquid biopsy, with this blood test, something that's comparable to mammography, but what we want is to be able to go further, to be able to find it even in earlier stages, so we can intervene earlier. And our research is heavily involved in that, and it turns out that one of the keys to overcome this problem is, if you think about the lottery analogy, is not to try and look at one particular site. So a lot of the approaches that are applied now is to look for a particular mutation that we know is often found in breast cancer. And what we innovated on with modern data science is actually to try to look for signatures across the entire genome. And to enrich our ability to discover those kind of rare events that come from tumor very early on. The analogy that I use is that every individual person has a very low chance of winning the lottery, but there's a good chance that someone would win the lottery. And that's exactly what we're trying to do. Instead of just looking for one site that has a mutation, we're trying to look for many sites to enrich the chance that we'll be able to detect it. And we've applied it to some tumor types and shown that we are able to go 2 to 3 orders of magnitude lower. And the hope is, together with other screening approaches, together with other preventative approaches, we'll be able to find cancer earlier, perhaps with a blood test, and to be able to monitor these small amounts of cancer cells over time dynamically, so we can say perhaps this patient has something there, but maybe it's quiescent. This person has something there that's growing and needs some intervention. So those are the major areas that we're developing, trying to use the notion of liquid biopsy to help us both optimize therapy when the cancer is established, to be able to combine therapies in a rational way, because combination is now a substantial challenge, right? If we have to combine 2 or 3 drugs with different doses and adapt it to a particular patient, it starts to break down the paradigm of building clinical trials, because you realize that the different combinations that can be applied grow exponentially, and our ability to recruit patients to long randomized clinical trials break down. So we need better methods to do that. And the complement of that is actually to be able to use those methods, those blood tests essentially, to go and discover cancer earlier, so we can potentially intervene earlier.
Okay, so the issue of early detection can be troubling, because we may end up, the earlier and earlier we look for some abnormality in someone's body, we may end up creating a world where everyone is a patient. And the interventions are not easy. I mean, these are toxic interventions. So we may end up doing more harm than good. And I'm wondering the extent to which the laboratory work is actually looking at lethal cancer trying to find it early, as sort of DNA land is trying to help in that regard. So that if you're looking for something early, what you're looking for are the things that we should intervene in, and also that we know how to intervene. Now, with Angelina Jolie, that wasn't looking for cancer, she was looking at risk. But when you think about it, that's an awfully big price to pay. She may have had an early breast cancer, if she had it at all, that could have been treated maybe with radiation or not treated at all, and not have any more toxic therapy, and never died of breast cancer. But the choices that women have now that we know more about genomics, but not enough about intervening, are really difficult. So how do we deal with that in this age of genomics?
I don't need this, maybe?
Yeah, I think, yeah.
I'm sorry? Good. Here you go.
Wait, yours is working?
Yeah, I guess so.
Okay.
That's a fantastic question. So the question is, we already encounter this problem in areas such as breast cancer, such as prostate cancer. We know that often we diagnose patients and give them the label of cancer, even though they would likely not have died of that cancer and could have had a normal lifespan without knowing and without succumbing to therapies that are potentially toxic. So the idea is not only to detect cancer, but also to be able to predict which patient will have a harmful consequence versus not. And I would argue that having sensitive detection can actually help us out exactly with this distinction. So many things in life we know we monitor dynamically. For example, we can measure a temperature. And maybe if we have a temperature of 101 just one day, it's not a big deal. But if you have a temperature of 101 for 30 days straight, then you would look at this differently. We measure things dynamically over time. If you go to your doctor and you have a high cholesterol level or a high sugar level, the doctor would say, well, maybe you had a heavy meal or maybe you're not exercising enough or something like that. And they say, well, come back to me in a few months and let's repeat it, right? That's something that we do in medicine all the time. We use dynamic information to distinguish between something that would be potentially harmful to the patient versus something that's not. And having these kind of quantitative angles to be able to quantify how is this population of cells behaving over time. We know, for example, that patients have nevi that have mutations that we see in cancers and yet remains very stable over time, over many years, and do not need any intervention. The ability to profile this dynamically over time can allow us to make prediction based on how the tumor fraction, the amount of tiny DNA molecules we find from the cancer, are changing over time. So that's one aspect. The second aspect is that actually this liquid biopsy approach is actually a little biased towards those cancers. So the reason that the DNA, those small parts of the tumor, actually find their way into the bloodstream is related to things that we know of that makes a cancer more aggressive. For example, if cells are growing faster, they also tend to die faster, and then there'll be more DNA spilling into the blood. If a tissue is behaving in a more controlled fashion, then there's not a lot of cell death and not a lot of DNA spilling into the blood. We know that cancers, when they become more aggressive, become more invasive. They disrupt the architecture of the tissue, and they also disrupt the blood vessels. And that makes those little DNA molecules spilling into the bloodstream more likely. So that's two ways in which this type of approach can help us not only detect earlier, but also help distinguish between those patients that need some kind of intervention and those patients that don't.
Yes, please. Just a second, we just need a mic, okay?
So, as you know, cell-free DNA is widely used in prenatal diagnosis, and there we have the advantage of marked differences in size compared to the maternal DNA and also epigenetic changes. Does the tumor cell-free fetal DNA also come in different sizes and have different epigenetics, so you can use that to separate it? Does it have that similar advantage?
Absolutely.
Just one second, so because there was some jargon in the question, I want to translate to a wider audience. Cell-free DNA, we refer to DNA, what Dan described, DNA molecules, these tiny molecules that are found in the blood. They're not inside cells. They are spilled from cells to the bloodstream, so we call them cell-free DNA. Yes, Dan. Yeah.
Should I repeat the question, or everybody heard the question?
You can also repeat it if you want.
So the question was that this concept of finding cell-free DNA has been used successfully in the clinic in the context of prenatal diagnosis. So the idea is that you can actually find DNA that's coming from the fetus in the mother's bloodstream. And instead of doing an invasive test to see if there are chromosomal abnormality in the fetus, you can actually find that in the mother's bloodstream and help the mother understand whether there are parents, whether there are any kind of chromosomal abnormalities that need intervention. And we are absolutely following in the footsteps of this technology that had the most incredible dissemination into the clinic. So from the point that these type of technologies and ideas were brought up at the bedside in the lab, the time from that to reach to consumers was like a handful of years. I think there's been very little example of any kind of diagnostic technology that took over so quickly as prenatal diagnosis and the use of those DNA particles that are spilling into the blood. What the gentleman mentioned is that there are, in addition to mutations, there are other handles that help us distinguish between DNA that comes from the tumors and DNA that comes from normal tissue. And again, because we're trying to kind of win the lottery, we're trying to find very rare events of this tiny amount of DNA that's spilling over from the tumor in the patient's blood. And it's a harder problem because, fortunately, we have fetuses are larger entities in most cases than cancers. And also because the fetuses are product of two genomes versus the cancers are modification of a single genome. And there are other examples of tags that can help us distinguish. One of them was the one that was mentioned, is the fragment size. So it turns out that cells dying in different ways and in different places actually have different in fragment size, and we can actually count this and use this as part of the detection. And the idea is to use different signals and big data approaches to amplify the signal and kind of go further and further into identifying it early and having the dynamic range to be able to monitor it over time and say, this is something that behaves indolently, and this is something. And fragment size is one, mutation is another, and epigenetic information that was also mentioned is another important source.
So you believe it's a promising area of research, clearly. How far from the clinic do you think we are? And how will it be tested to see if it actually results in a benefit in overall survival?
My personal bias is that I'm not consulting to anyone, so there's no commercial bias, but I think that this would really recapitulate what happened in prenatal diagnosis, that it really took the field very quickly to adopt these technologies because they offer so much. And we already see application of this in the clinic in the setting of established cancer to overcome the burden of spatial differences in patients with metastatic disease. So for example, you can have cases where patients have metastatic disease, they'll have one lesion in the bone and one lesion in the liver. And you're trying to find the best drug for that patient. But before, the only option we had for genetic characterization was to take the patient to the operating room or to the interventional radiology suite and submit the patient to interventional procedure in which we extract the part of the tumor. The problem is that we can have to choose. We'll extract the part in the liver, but then we don't know what happens in the bone. We'll extract the part in the bone, we don't know what's going to happen in the liver. Liquid biopsy, this ability to look at DNA that's shed into the bloodstream, allows us to sum the genetic characterization over different spatial loci. And that is already making its way to prime-time clinic, again, very rapidly, within a couple of years from its introduction. I think the next place where this would make an impact, a clinical impact, is with therapeutic optimization, because there's a precedent for that. We have been using this in other diseases like leukemias for many years. We use something called minimally residual disease. How low the disease go when you treat it. We've used this as an informative prognostic and therapeutic aid for many years, using the fact that these cancers reside in the blood. So in this case, it's an easier case. I don't have to look for DNA that's shed from a tumor in the breast or in the liver. All of the tumor is found in the blood, and I can use this. So I think
then
that
it just moved. I think some other questions over here. Yeah.
So when you find these supposedly early cancers in the blood, how do we know that the immune system isn't going to take care of it before we start treating something we found in the blood?
I think that's another good question that we don't have good answers to. We can use dynamic information over time to answer those questions as well, because we will expect to see areas where we see the fluctuations, or we see changes, downward changes in the frequencies in the blood that are autonomous, that are outside of our therapy. And we'll need to get more samples, more information to be able to say what are consistent changes that would suggest that that tumor avoided the immune response, that tumor escaped the immune response.
So kind of like also to answer this question, your question about the value in the clinic, there is a company right now called Grail, and it's a Silicon Valley company. They raised over $1 billion. They raised over $1 billion to conduct clinical trials that of 500,000 people. They're going to take healthy individuals, trace them over 5 years, and sequence the blood, like what Dan described, this liquid biopsy. They were going to apply this technique for these individuals. Now, statistically, some of these individuals will develop cancer spontaneously. They can then go and see what they found, what was the sequencing results. So with such a large-scale study, we're able to exactly answer those questions. Whether this early detection, everyone is going to be a patient. Do we need to intervene? Maybe the immune system is going to take over. And really to understand better what to do with this information. This is kind of like when people developed the microscope and found new things, this is kind of like the new microscope to look at what happens, kind of like the blood as a window to the cancerous process. And we just don't know many things, but it seems very promising.
So we're working with Grail. Project lead graduates from NBCC are working with Grail because we're asking them the kind of questions that I asked earlier and working with them to make certain that this isn't just going to create a new group of patients and will have true clinical benefit. It's not hard to raise $1 million when Illumina
A billion.
behind
$1 billion
when Illumina is behind you. So, yeah.
There was a question over there at the back.
So with this concept of early detection and potential treatment, we're talking about essentially a new type of disease, right, and a new type of indication. You have treatment of localized cancer, that could be radiation, could be surgery. You have treatment of metastatic cancer, that's chemotherapy, biologics, etc. Would you classify this as a new type of cancer? Just, there's this dormant cell floating around the bloodstream. And if so, getting back to a previous question, how do you demonstrate efficacy, and would drug products have to have new indications for this particular type of treatment?
For me? Those are precisely the questions that the field in general is kind of going after. And we started to work with part of the moonshot initiative. There are sort of working groups that are coming together, and one of the working groups is aiming for something called the Pre-Cancer Atlas. As a clinician, I can tell you that we've known for many years, and there's a lot to support this, that the earlier we can detect tumor, the earlier we can intervene, the better our results. When patients present with metastatic disease, even with new sophisticated therapies, often they're already with disease that's not curable or that would be cured with a lot of toxicity. And now we're marching towards a new era, just like you said. We're marching towards an era where we're moving to maybe a new entity, which is this pre-cancer. There's experience with that. So there's experience with going towards pre-cancer, for example, in cervical cancer prevention, an experience that has been very impactful and had major impact on health, right? So patients undergo pap smears for many years now. And what they detect with those pap smears is what's called cervical neoplasia in situ. So that's what we call pre-cancer. That's not a cancer. It's not invasive. It's not spreading beyond a very thin layer of epithelial cells, of cells in the cervix. And yet we know that if we remove those lesions, if we find them early, there's proof that we can detect and decrease the likelihood of getting lethal cancer.